presentation, we create learning opportunities for the clinician presenting as well as the audience members, and throughout that presentation, we then send the clinician off with some recommendations and next steps that they can look to and potentially implement with their client in particular. So we will begin with our didactic presentation. We're very fortunate to have Dr. Courtney Burnett and Dr. Sean Quigley joining us today. They will also be joining us for our next clinic, and they will be presenting on best practice care coordination with psychologists, as well as interpreting and incorporating the diagnostic evaluation into our ABA treatment plans. So whenever you two are ready, we are looking forward to your presentation.
Good morning. Thank you all for having us here. We will be talking today about interpreting comprehensive autism diagnostic assessments. And for those of you who have seen these or written them, you know that they can be quite and cumbersome. So we thought we would try to kind of demystify some of the information that are in those reports and really help understand why that information is there and let you know kind of what are those important components and how we arrive at a diagnosis of autism or other diagnoses as well. So what we'll be doing today is talking about the components of a comprehensive autism diagnostic assessment. We have the word comprehensive in quotation marks for this because it's talking specifically about kind of what are, from our state guidelines, from the New Mexico state guidelines, what is considered a comprehensive diagnostic assessment. And these are specifically represented in our billing guidelines for Medicaid services. And then the next point that we'll be talking about is the key components of a diagnostic report and what are those features that lead us to the diagnosis, what is included, what is not included, so kind of not what is not considered within the scope of a comprehensive report. And so recommendations that you might see that would direct a family to consider other things that are not part of that report. So we'll be reviewing that as well. So the main point of today, what is a comprehensive diagnostic assessment? In the state of New Mexico, we have what are considered by these billing guidelines for Medicaid, autism evaluation providers that complete these evaluations, and those individuals who are qualified to be an AEP or an autism evaluation provider is a doctoral level clinical psychologist or a physician who's board certified or board eligible in developmental behavioral pediatrics, pediatric neurology, or child psychiatry. In addition, that individual needs to have knowledge and experience in ABA and other empirically supported treatments for ASD. So there's many clinical psychologists and physicians who have these credentials, but maybe don't have that particular knowledge and experience in ABA or in autism. And so really what's considered to be approved as an autism evaluation provider, you need both of these components for meeting criteria as a provider. So really what we're looking at, and when we consider a comprehensive diagnostic evaluation, is we're really looking at multiple areas of functioning. And this includes areas of development, of speech and language, of medical concerns, medical history, and it can be educational records that we have in terms of how that child is functioning in that setting, or other intervention records. So really what we're trying to do in order for the evaluation to be comprehensive is gather information across informants and across different modalities. So really what that can mean is we want to, for the informant piece, we really want to observe the individual, of course, and do testing with the individual. We want to get information from parents and really understand what that child is like in other contexts and at home, not just currently, but also what they have seen developmentally over the course of that child's life. And then we really want to gather information from additional informants as well. And that would be, like I said, educational providers, intervention providers, and medical providers. in terms of how we gather that information, that can be a number of different methods as well. We really request any kind of previous evaluation reports that would give us any indication of what that child's functioning was like prior to the actual appointment day, and how it's consistent or not consistent with what we're observing in clinic. We also want to do an interview with the parents or other providers if needed. Sometimes that can be school or therapeutic providers. And we want to do observation of that child, just understanding how they're kind of functioning in the clinic setting, how they interact with their parents, how they interact with the clinicians that day. So we're really looking at observations of their behavior and of anything that we're noticing kind of within a new context of a clinic setting. The next part of that is we really want to do an autism-specific assessment. So that includes a measure or observation, most often the ADOS, which is the Autism Diagnostic Observation Schedule. And that allows us to really structure an assessment and look at a number of different areas of functioning for that child. For the ADOS, for those of you who haven't seen it, there's a number of different activities. It depends on which module you're administering, but there's a number of different activities that really allow us to observe a child and how they're communicating socially, how they're communicating non-verbally, what different activities they prefer, and how they're interacting and what is their social reciprocity with the examiner. So that's a very specific assessment that we're doing. And in terms of the other autism specific piece, we're also asking parents for a developmental history and behaviors that are consistent with that diagnosis. So we want a general developmental history in terms of how the child has been doing, just in terms of milestones, in terms of independent behaviors, in terms of any medical concerns or family environmental concerns. But we also really want to get an understanding of what are their behaviors that are very specific to a diagnosis of autism spectrum disorder. You can go ahead to the next slide. The other piece of autism evaluation report that you will likely see are standardized tests related to language abilities, cognitive abilities, and any other medical or behavioral health issues. We know that that there's a number of comorbid diagnoses related to any of these areas that children with autism spectrum disorder can also have. And so in order for this to be comprehensive, as we're looking at different areas of functioning, different informants, and different ways of assessing information, we're also looking at language abilities, cognitive abilities, medical concerns, and any behavioral health issues. This is really to address all the different areas of functioning that may be impacting that child's behavior, and that may be really important for then an intervention provider to take note of as they're working on a plan for that child. After the comprehensive evaluation, after all that information is gathered and a report is written that really clarifies, hopefully, each one of those different areas to provide an understanding of the child in multiple different ways. What part of our guidelines for New Mexico are that we develop what's called an ISP, or an integrated service plan. And what the integrated service plan is designed to do is to really guide stage 2 treatment planning for ABA services, as well as any additional intervention needs. So what we're doing is we're taking recommendations that not only relate to kind of our recommendation for ABA services, but also what are other areas that a family or that an intervention provider needs to pay attention to. Again, this can be any therapeutic services, speech language occupational therapy, early intervention, any medical issues. So what you would see outlined in an integrated plan would be not only the recommendation for ABA and areas to address with that, but also what are the other recommendations that are impacting that child, other recommendations for treatment that would address those needs of the child that were determined by that comprehensive evaluation. So Sean's going to start the next couple of slides because he's got some fun pictures that he wants to share. But really to summarize, what we're really doing in a comprehensive assessment and report for that documentation of the assessment is we're not just doing an assessment that is based on a single observation of a child on an ADOS or on a cognitive test or in a clinic setting. In order to make a diagnosis of autism and consider other comorbid conditions that we know go along with that diagnosis, what we're doing is we're gathering information from a variety of sources that are both current as well as historical. So an autism spectrum disorder is a neurodevelopmental disorder. So we know that there have been symptoms that are present over the course of that child's life. And we're really looking to gather information from both the developmental history as well as the current functioning, both from our own observations as well as from previous evaluation reports, intervention providers, and families, so that we get a comprehensive view of that child and a comprehensive understanding of all that might be at play for that child and family, so that then we can make comprehensive assessment recommendations, comprehensive treatment recommendations that are then outlined in our report, but then more specifically in that secondary document, which is the integrated service plan.
Yeah, so hopefully this picture of the donkey kind of, sometimes as a stage 1 provider, this kind of feels like where we're at. There's a big load to be carried in terms of the role of that stage 1 and getting through the assessment and determining kind of sometimes that big question of autism spectrum disorder. So that's what the donkey's all about. And then this picture, hopefully maybe sometimes it's the stage 2 and 3 provider. This may be what you guys feel like in terms of getting information from the stage 1 and all this information and paperwork and how to roll through it. And so we understand that sometimes can be hard. And then we have this guy who perhaps represents a parent who gets a whole load of information from not only the stage 1 provider, the stage 2 and 3 provider, the insurance companies, the school entities, they're just getting probably overwhelmed with information. So it's thinking about through this process of stage 1 through 3 and everything else that's going on in families' life, how do we communicate information and not hopefully be overbearing on families like this. So what I wanted to chat about just real quick in terms of that, the document that's going to be the piece that hopefully guides stage 2 and 3 is that integrated service plan. And so there's 10 components based on our billing instructions for the state of what the ISP is supposed to cover. And so what I want to do is maybe just talk briefly about a couple of these and share some thoughts about them and what you might expect to see in those ISP reports. So the first piece is that question about, the diagnosis of autism, and then secondly, is behavior analytic services medically necessary? And if you guys remember, if you were here on the ECHO a couple of weeks ago, Dr. Lopez spoke more in detail about that medical necessity, but again, simply stated, there needs to be a statement indicating the treatment, particularly behavior analytic treatment, is needed to improve functioning. I mean, that's the core essence of medical necessity. And so that's one of those pieces that if you've given the diagnosis on the ISP, you're going to see some statement along those lines. Another piece to perhaps look for is Dr. Burnett talked about is the severity of the autism symptoms, through development, through the testing and different things like that will be guiding you guys as providers to understand perhaps what assessments might be warranted, what level of service might be warranted for this individual and things like that. So there should be some level of information about severity of those symptoms and perhaps other non-ASD symptoms in the ISP report. With all areas of need, the ISP guidelines indicate that you have to have broad goals for service providers. And so again, as a stage 2 and 3 provider, these are going to be what you're seeing in terms of broad goals, such as assessment perhaps for challenging behavior, assessment for language, assessment related to social communication, things like that. You might also see other broad goals that might have come up through that stage 1 service. Some that may be more clarified than others, but there might be mental health concerns that need further assessment and or treatment. There might be medical concerns. You might see things like genetics referrals based on their genetic history or other indicators of genetic concerns. You might see sleep concerns, things like that. And so those might be on the ISP. Again, you might see family needs on there in terms of broad goals. And then part of the ISP too is each of these goals, the stage 1 provider has been asked to give a priority to. And so how do you do that? And so over time, it'll be interesting to see how stage 1 providers kind of assign priority to one thing over another. But generally, we are looking at things of talking about there's a need or a goal that's urgent for perhaps there's a self-injury that's really putting the individual at risk of harm to themselves, and so that's an urgent goal that needs to get addressed really quick versus like an adaptive skill, maybe like toileting, might be put as a low priority versus as compared to some other things. So I think this priority area is going to be an interesting thing to see how it shapes up, and it'll be relative. What's a priority for one kid might be a low priority for another child because they have other more severe presenting issues. So that's something else that you guys should be looking at, and hopefully being communicated to you through the stage 1 provider, through their ISP. There should be some level of communication of priority. Another area on the ISP, one of those 10, is that how are we supporting access and participation in school services? And so generally for us, what we're talking about is that we are providing a broad statement that the family and the stage 2 and 3 providers and other providers in the family, for the family and the child, need to begin the conversation around what access do we have to either Part B or C supports, and are we eligible for those, and are they needed for the child? And so for us, it's not a statement that they need those things. It's a statement that they need to begin that separate, distinct process to evaluate whether or not school supports are needed and to what extent they're needed for that child. We just want to be aware that there are other providers out there that play by different rules, so to speak, and have different processes. And so we want to be careful about trying to just say, they need to do X or Y. Another piece on the ISP, or part of the 10 requirements, is having a realistic assessment of available resources. So some of the questions we're asking in terms of when we're completing ISPs are, is there an ABA provider in the area? If not, how are we helping support the family, gain access to those type of services? Can the family maintain a rigorous treatment schedule if that's, necessary? Some of our kids have a lot of needs, and what's their ability to get to those appointments, to manage various schedules, what other siblings they have in the home, and what kind of, how do we have to balance time between all the family? Other pieces are like cultural variables. How are we being aware of those variables and helping people understand that there might be cultural variables that enhance or impair service delivery? So the ones left here in white are kind of the ones we talked about. The ones in red are somewhat more of, depending on how people put together their ISP and whatnot, the ones in red become a little more difficult to have like a formal piece on the ISP perhaps. For example, like address ASD symptoms and comorbid symptoms. Hopefully, if you've done a good stage 1 assessment, you're going to identify some of those things. And by virtue of having varied goals that meet all the needs of the individual, those would include ASD and comorbid. Or balance the current clinical presentation and long-term potential. Again, I think that's part of which goals you choose for the individual based on your clinical expertise and based on the family input or the school or other professional input in terms of which goals are good now for the clinical presentation versus what's the long-term potential. So again, there's not really that's reflected in how you do other things. So those ones in red, at least for us, the way we look at them, are kind of apparent based on how you do some of the other things in the ISP. So that's kind of why they're highlighted here in red. So with the ISP, again, this is information that's supposed to help guide stage 2 and 3. And there are certain points of information that aren't determined in stage 1. And so some of those things that are determined in stage 2 or elsewhere is, for example, the program type. Are you looking for a focused program versus comprehensive? And does that meet the needs of the individual? So that's determined, in stage 2 or elsewhere. The specific tests or assessment procedures guiding intervention development, that's really determined by the stage 2 provider as opposed to by a stage 1 provider. Specific intervention procedures, again, there might be broad goals around, a need to increase social communication, and that's the goal, as opposed to giving an explicit procedure to say this is how that should be done, or to how to reduce challenging behavior, for example. That might be the broad goal, but not a specific, intervention mention. Excuse me. The other piece is that school eligibility, the placement within different types of school programs, academic needs. Those are pieces, again, determined perhaps in conjunction or concurrently with stage 2, but are kind of a process outside of the, ABA billing guidelines or this service delivery. It's a school-based service, and so those kind of information decisions are determined elsewhere through their processes. So those are a few pieces in terms of things that are not covered in stage 1 but elsewhere. And we don't think that list is probably comprehensive or exhaustive, but those are just a few examples. So again, in summary, I think the big thing about the ISP is it's taking everything that Courtney talked about in terms of multimodal, multi-informant, ASD specific, and it's taking that information and summarizing it in a meaningful way for later practitioners to guide them with broad goals that they can then take and work on and work with the family and other providers to then achieve the needs for that individual. And that's kind of the goal of the ISP. And I think that's generally all we have. Pretty simple. Maybe some of it, though, is it's sometimes really hard to get into some of the details, but that's hopefully useful to you guys.
Wonderful. Thank you so much for that overview of the diagnostic evaluation process, and then specific to the state of New Mexico, the ISP procedures. Does anybody have any questions that they would like to take this opportunity to ask Dr. Courtney Marquette, Burnett, or Sean Quigley?
I have a question. This is Kathleen with BCI in Oakland, California, and I'm wondering, once this report has been created, what happens next in terms of reviewing it with the family and answering their questions?
So I think that's different for different providers. Certainly what we do is we have a feedback session. We will review all of our recommendations and give them resources at that time in terms of what are our next steps. We also have social workers who work on our team who will contact the family afterwards and look for, ask them about questions that they may have after they've gotten the report, or are available to meet with the family to discuss any concerns, any questions related to autism, or any follow-up, maybe with accessing appropriate services. So different providers may deal with that differently. That's generally how it works for our clinic.
Great, thank you.
I have a couple of questions too. This is Zoe, one of the hub panelists. I guess first, is an ISP provided for all evaluations where a diagnosis of autism is given?
Yes, that's correct.
Great. And then the second is ABA always recommended and discussed in that ISP? Or should it be?
Oh yeah, so the ISP is specific to direct. It's almost like the kind of, in addition to the report, the ticket to access and to get eligibility through Medicaid for ABA services. So that ISP is specific to ABA, but also because it's called an integrated service plan, really outlines other areas of functioning and recommendations that are impacting that child.
Brilliant. And if the child doesn't have Medicaid, do they get that ISP as well?
Yes.
Great.
The eligibility and coverage for other insurance companies, as I'm sure you know, is coming along, and will hopefully adopt some of the same procedures.
Great. And one last question. If there aren't available resources in a family's community, how is that sort of addressed or supported, or sort of how do you all work with that?
So part of what we're doing right now that, like BCI or other folks we know is we are trying to work in the state to help build capacity of providers. And so recently, there are new providers coming into the state to fill niches in various areas or statewide or whatever. And so if we do have that, our family resource team tries to help locate other service providers that maybe aren't currently in the state. We're working on a few providers to fill niche areas like the Farmington, Bloomfield, Shiprock area. Doesn't have a lot of providers. So different things like that, or we'll get creative. I mean, I've cold called a few people in Texas and just said, hey, is there any chance we can talk about the needs of a family that, are kind of down in that southeast corner that needs some supports. We also just try to refer to all the known providers and help them be educated about just asking questions and saying, you're already established in the state. Is there any way we can work to serve needs in my area?
Well, great. Thank you so much. That both the answers to the questions as well as the presentation was super informative and super helpful. Thanks so much.
Great. Thank you, Zoe. Does anybody else have any questions? Great. And another piece that I really enjoyed that you included in there were assessing the treatment barriers that a family might encounter and that might prohibit them from either accessing their ABA treatment or fully utilizing their ABA treatment. And one of those was specifically related to the family schedules and whether they can actively participate. And I think that that's another underlying theme of this ECHO project and applied behavior analysis is how do we identify and assess those treatment barriers and then through coordination of care address them so that a family can fully utilize the benefits that they're able to access, not only in the state of New Mexico, but in other areas as well. So thank you for including that and providing such a thorough review. We are very much looking forward to having you join us again at the next clinic. All right, so we are going to move on to the next part of our clinic today, and we have Christelle who will be presenting a case that she is here to seek some consultation as well as share what she's done thus far with this case. Just as a reminder, our ECHO clinics are HIPAA compliant, and so we do not share any client information. All of the client information has been redacted from the case presentation forms that we'll be showing today. If for some reason we do have any client information that is shared, we will of course remove it from the video and then just use it as a learning opportunity for all of our participants as well. This is a warm and welcoming, safe learning environment for not only our presenters, but also for our participants. And so we encourage you to feel free to ask questions and participate in the recommendation section as well. Christelle, if you would like to go ahead and begin, I believe Haley is getting your presentation ready.
Hi, can you hear me? Good, okay. Well, my name is Christelle Garza. Thank you so much for the opportunity of presenting this case. So I'll be presenting on a case. The patient is a male, 13-year-old, just turned 13, and he has been receiving services with BCI for 11 months. He has come with a set of challenges, and we've definitely come a long way. And today I'm presenting specifically about this new behavior that started about a few months ago, about two months ago, that involves fecal smearing and fecal digging. And This kiddo is a very high functioning kid, and I'll talk a little bit more about him. But some of his primary goals of care has been reducing problem behaviors, teaching emotional regulation strategies to handle his emotions, instead of having outbursts, teaching appropriate communication, improving his social skills, and adding that self-monitoring component, being that he's very high functioning kiddo. Throughout this 11 months, I've consulted with a variety of BCBAs at different times for different reasons. So I've been very fortunate to work with quite a few BCBAs throughout this time with him. Some of the assessments that I've done is the AFOLS and the FAST that I've done for other behavior problems, and currently for this behavior problem too, the parents had fill out the FAST. So some of the treatment objectives have been reducing problem behaviors, teaching emotional regulation strategies, improving that communication, verbal and nonverbal, increasing social behavior as he's 13 and he demonstrates interest in having social interactions and is not always sure of how to go about those. And also improving his interaction with his siblings, and increasing his awareness by developing different self-monitoring strategies and using some different skills to help with that. His primary diagnosis is autism spectrum disorder level 2, and he has also been diagnosed with attention deficit and hyperactivity disorder and oppositional defiant disorder. He is currently taking a variety of medications, melatonin, Zoloft, Seroquel, Zyrtec, Intuniv, and VNs. They had played and modified his doses quite a few times, but this has been a consistent set of medication for a few months now. He doesn't receive any other type of additional treatments, and his primary language at home, well, actually the only language at home is English, and he's currently attending a new school. He was moving to this new school about 3 weeks ago, almost, and this is a PBIS school, and he is being a lot more successful in this environment. He goes 5 times a week for 6 hours approximately, and he has been receiving ABA for 5 times a week for 2 hours for the last 11 months. His family involved his mom, his dad. He has 3 siblings: an older sibling, an older brother, and a younger brother and a younger sister. So he's the second one. Both of his parents are involved in treatment, but mom is the main caregiver. Dad, he is military, and he is involved as much as possible whenever mom is unable to be for different reasons, but mainly mom is the one that most conversations happen with her. However, they do work together, and that's something that I've been very positive and very excited to share with mom, of how I see them working together and being on the same team, and mom sharing whatever was discussed with her if he wasn't available. So they definitely are doing a good job in trying to work as a team. He can communicate vocally. He has an extensive language and continues to learn new vocabulary as days passes. He is very interested in knowing certain words mean and using them appropriately. Some of the challenges with that is maybe not always using the appropriate communication skills that he has. So if the situation is stressful, hard for him to deal with, like sometimes he still goes back into those just exploding or having all those other challenging behaviors instead of communicating appropriately. But we have come definitely a long way in that. So let's talk a little bit more about the current challenging behavior that I'm coming here to seek consultation on, and involves fecal smearing, that we have defined as smearing, playing with, touching, painting walls, or saying bathtub with his feces, and fecal digging, that involves an instance of engaging in digging in his rectum with his finger. I should say, when I'm defining these behaviors, that defining these behaviors has been extremely challenging, and due to his age and his cognitive level, certain things have been available and certain things haven't been appropriate, and So our definition has been mainly based on the description the parent has provided, because the parents do provide 100% the monitoring over this type of behaviors. He is very embarrassed about this, and he is embarrassed about anyone seeing him like without wearing clothes, even his parents, but he's okay with mom and dad, but obviously would be completely averse for a behavior technician to go in and monitor any type of behavior, so we haven't done that. And the behavior technician, however, has been able to observe some of the, let's say, proof of the behavior happening, such as the towels, the sink, the bathtub with feces smeared on them, and remainder of feces in the bathtub floor or in the sink. Been talking a little bit more about the fact that he is embarrassed. He makes different attempts to, and he's actually very good at covering his tracks to avoid being caught. So he is able to know what things mom is going to be looking for, or when his mom is going to be coming in, etc. And he tries to clean after himself and does it very effectively up to a certain extent. So that's been definitely another challenge. Currently, this has happened one daily for the last 3 days, because we had a last instance yesterday. So it's been 3 times. And usually this happens when he's alone in the bathroom. Either he is taking a shower or he is using the toilet, and this is usually when this has happened. And this is the, Haley, if you can show the FAST that the parents filled out. This has been recently filled out by the parents. So my initial recommendation to the family when this barely started was that we were going to monitor the frequency of it, and based on what we could observe, and we will, I was highly recommended that they will go see a GI doctor, make an appointment to make sure that health-wise everything was fine. They're a military family, and they're currently in the transition between one PCP and another, and for that reason they haven't been able to schedule an appointment, and it's been a few months too. So after consultation with a variety of behavior analysts, we decided to put in place some antecedent and reinforcement interventions that I guess we could do in the meantime while that appointment was set. And our interventions were monitoring him consistently when he's in the bathroom, either taking a shower or sitting in the toilet, by mom, obviously, the monitoring, and allowing him unlimited access to FLARP. And I'm not sure if you all are familiar with FLARP is, but it's a gooey substance that feels kind of wet, but it's not really wet, because when you take it away, your hands are completely dry. So he was given unlimited access to that FLARP at any time during the day, except at the time that he's in school, because we couldn't allow that, and the school wasn't able to allow that while he was there with other kids. But in a consequence or the reinforcement procedure that we introduced was, if we couldn't find any proof that he had access to, or he had any type of incident while in the bathroom, he was allowed immediate access to the iPad without having to follow his normal plan, which is a point system that he gets to exchange points for. So this was just kind of free access to the iPad if we couldn't observe anything, if parents couldn't observe anything, and if there wasn't proof that he had engaged in some type of behavior. So I will show you guys this graph, and I'm calling it fecal incidents because our definition has been so challenging that we just kind of involve all incidents. And with that being said, some of these incidents involve like us noticing the towels. Not really, mom didn't see any instance happening, but towels with feces smeared on them after he showered, or like the remainders of feces in the bottom of the bathtub. And parents do have to keep a close look at that, because I mean, he attempts to clean up, so it's usually hard to find, let's say. Sometimes it's not as hard, but he does a good job at cleaning up after himself. And toilet paper with feces has been one other thing that feces, but this toilet paper is hidden somewhere else, not in the trash can. So some of these data points are based on like the I guess leftovers, and then some other data points that are more specific, more clear, has been actually parents observing him with his hand inside the toilet while he's having a bowel movement, or they walk in and they see that he's smearing feces on the bathtub walls, or that he's playing with his feces on the toilet while squatting and just looking and playing, or and now when we go back into the baseline, we remove our 3 interventions. The monitoring, we removed the access to FLARP and the reinforcer of the iPad, which is kind of his highest reinforcer available. And when that happened, we still needed to monitor kind of his behavior to see if there were any things that were happening while he was in the shower. So parents have been like peeking in. They stand on the toilet and they peek and see if they can. Usually he will be squatting if something like that is, if he's having an incident that day. So those are our data points now that we brought it back to no interventions being provided. The next graph shows a little bit of the access to FLARP during the day. And at the beginning, he was using it for about half hour or so. And the days where we see no access to FLARP are days that, I mean, he is very, he enjoys being outdoors. So there were times when FLARP was available, FLARP was offered, but he was playing outside and he much rather not go inside. And so he wouldn't engage in the use of FLARP at all. And now, since we went back to no intervention, there hasn't been any access to FLARP. But I do have to say that at the beginning, he started by asking for it once. He knew that the behavior technician was the one that brought the FLARP in, so he asked specifically her. And then this last few days, we had consistently asking for the FLARP, not only to the behavior technician, but to mom at school, to dad. And just yesterday, during his session, a 2-hour session, he asked for it 3 times. So, and he's just told that it's not an option right now. Well, and let me talk a little bit more about like the schedule that we had kind of being able to identify for his bowel movements. So since we started monitoring him, he started going, using the toilet less times. So with that being said, he uses the toilet the first thing in the morning when he wakes up, and parents had reported that time is only urination, there's no bowel movement going on. Based on the weekends, what we can observe is that he usually goes after lunch, and during that time, it usually has a bowel movement from what parents say. And it frequently happens also during the time of session, which is around 4 to 7 p.m. We asked him when he was having bowel movements, and he told us that feel like now recently he's been needing to go at school, and usually it happens during math class, surprisingly, and it's usually after lunch anyway, so it kind of goes with his schedule, but specifically falls into math class consistently. In the last few days, so as I was saying, like he was moving to this PBIS school, and it's been about 3 weeks since he's been there, and they weren't having any type of issues with him requesting to go to the bathroom more than, what the normal be for any other kid. Just this week, Monday and Tuesday, parents receive phone calls that now he's spending 30 minutes in the bathroom, and he's spending a long time there. And so the suggestions or the procedures that they had put in place that will be that he will have to visit the nurse and use the bathroom there at the nurse office, and he will have to be escorted there, and they can monitor him washing his hands and using hand sanitizer after. But the school has told us in different told the parents that they are not able to monitor anything else because they're not able to go in there with him or monitor anything after. So if our data is based on parent report, like we basically have no data from the school. Although this new school has been, working a lot closer with mom into at least making sure that they limit or they keep an eye on how he engages in just actually going to the bathroom. So that is basically in general what's going on. One thing I almost forget is that we asked him recently of how often he goes to the bathroom to see if that will match with what mom and dad are saying of how often he is using the toilet to have a fecal bowel movement. And he also said that he's going in the middle of the night, or he has the need to go in the middle of the night, which parents are unable to confirm that because he has like an alarm system on his door, so they will know if he opens the door, and they haven't realized that he's opening the door in the middle of the night to go anywhere. So we don't know if this is really happening or not. Or also they haven't found any type of anything that will make them believe that this is happening, like let's say in his room or anywhere else. So we don't know if that's happening or not. Regarding family dynamics, they definitely could benefit from some support, peer groups, counseling, and this has been recommended. And different groups have been, like a list of groups have been provided to them, and they just haven't followed through with the recommendations. And they find it, and they have told us they find it a little bit hard to share their experiences or being put in the spot because, well, their kid is a 13-year-old and he's very high functioning, and for the most part, aside of behavior issues, like he looks just like any other kid, and it would be pinpointing their family. So it's a little bit of a tough thing to do. Mom does have a very close friend, and she is sometimes part of the session, and she's the one that is like, she kind of knows what's going on, and she's a big support system for the family, her and her husband. So that's kind of where we at.
Thank you. Thank you, Christelle. That was a very comprehensive overview, and I really appreciate you taking the time to review that. So just in quick summary, we have a 13-year-old male boy that was diagnosed with autism spectrum disorder, ADHD, and ODD. He's been receiving ABA treatment for a little under a year. He's also in a new school setting, not receiving any other ancillary services at that school that we're aware of currently. Within the last 3 to 4 weeks, there has been a new behavior that's emerged of what we're calling fecal incidents, which includes some smearing, rectal digging, and it's been a little difficult to observe just due to the nature of the behavior and when it's occurring. Parents have yet to take him to see the physician to rule out any underlying medical conditions. With some procedures that have been put in place, we have noticed a reduction and have since done a reversal while we've been waiting for the parents to take them to see if the behavior reemerged, and have seen that it has. That you had sent some updated graphs. Unfortunately, we had some technical difficulties. And so those updated graphs were not shown on the screen, but I have seen those, and we can pull those up as well. And it looks like the behaviors occurred for the last 3 days as well. So you are here to seek some recommendations after the parents have completed their medical evaluation on some potential next steps that you can evaluate and look into for him. Does that sound like I summarized everything? Okay, wonderful. Now we have a couple people that joined us. I want to make sure that we have the opportunity to introduce our parent panelist, Sarah Baca. I'm going to unmute you so that you can introduce yourself to the team.
Alrighty, good morning or afternoon, I guess. Sarah Baca from Rio Rancho, New Mexico, and I am parent to an 8-year-old son, Preston, that happens to have autism, as well as the executive director of the New Mexico Autism Society. Thank you.
Wonderful. Thank you so much. Okay, so then following the case presentation, we'll move into the next part of our training where we ask for clarifying questions. And so the participants in the audience, you have an opportunity to ask a clarifying question about the case. And if you have any questions, please feel free to unmute yourself and ask those questions now. Oh, and if you do, just a reminder to please state your name so that we can to know everybody that's in the audience.
Hi, Christelle. This is Denise Weaver.
Hi.
I have two questions. One, have you ruled out any possibility of any traumatic events that happened, immediately prior to this behavior starting? And then two, I just wanted to know why the family changed his school.
No, we haven't ruled that out. However, when this barely started, when this behavior barely started, in the first few days of conversations with the mom, she shared that this wasn't quote unquote new, that this has happened in the past when he was 3 and 4 years old and he was toilet training. So this information I was not aware of until we started having this incidents again. So from mom was surprised that it was coming back, and some of her concerns were like, has this been happening for the last, I don't know how many years, and I didn't notice, which, so it was a little bit of like blaming herself of maybe this has been happening in my own house and I don't know. But, so with that being said, it's like, all of the things that we are seeing based on parent report had happened. So I don't know if it's necessarily, but no, we haven't ruled out any other type of traumatic experience. And they did not try on purpose to change schools. So the way, this is a whole different story, but it's important. So the way this happened is he was attending one school, and he came from a Department of Defense school to a school district, and the school district did not recognize the autism diagnosis. So they took away all of the, different modifications that he had on his IEP, and they started treating his problem behavior as just challenging behavior for a teen. So for that reason, he was moved into a different school for challenging kids. He was there for about a month or a month and a half, and he finally met the requirements, and their mom found some supports in the community that were able to put in his IEP that he needed a re-eval, and that he also needed school that was based on PBIS strategies. So for that reason, then he was moved into this new school that is a much better environment and where he's doing a lot better. So that was the reason why he switched.
Excellent. Anybody else in the audience have questions? Okay, perfect. Like to wait the whole 10 seconds. All right, so then we are going to move on to our panelists, and we'd like to start today with Dr. Soule and get her perspective on potential underlying medical concerns that might want to be considered.
So thanks, Joy. I guess I shouldn't say I really enjoyed listening to the case, but at the same time, it's a little creepy. At the same time, I find that this is a really interesting topic and actually something that I've worked with in my clinic. So to remind everybody, I'm a pediatrician, autism medical specialist, and have some interesting thoughts about this kiddo. So questions. I am curious, do you know if this child has any pain associated with a bowel movement?
No, well, from what he has explained, he doesn't. He has never complained to the parents in the last year or so about any type of pain. Mom did explain to me that in the past he suffered from constipation the last 3 years or so, and this was something that will come and go, and with working with his doctors, they were able to identify what it was. Apparently this is something, a condition that is like in their family, so it's not only him that exhibits that, but within the last, so mom monitors that because for that reason.
Mm-hmm. Do you, another lovely question, has mom or the child given you any indication of what the consistency of the stool is? So like loose, runny, hard, pebbles. I mean, I could go on and on. There are actually visual schedules, or not visual schedules, there are actually visuals for the size and consistency of your poop, which is awesomeness. But any idea about that?
From what parents describe, totally normal, the way it has always looked. It doesn't seem like he is having a hard time having a bowel movement. It's from what they've observed and from what they see like remainders of in different areas, it looks totally normal.
Okay. Okay, a couple more questions. Do you know if he's had any fecal smearing at school? I know you mentioned that he's going to the bathroom at school, but has he had any fecal smearing or any of the other fecal stuff at school?
Not that we know of. That being said, it's like the monitoring at the school is really not there.
Right.
Something that mom had mentioned is that one of the things that she says that she can know for sure if it happened is that he washes his hands after it, but he doesn't check under his nails.
Yeah.
And when he goes to home, there's been a few occasions when mom can smell it in his nails. So like we think it's happening, but that's all we have.
Okay, thanks. That's helpful. I still have another question, but the reason I was asking that was for that very reason. Like, has anybody smelled it? Do the other kids complain? Does the teacher complain? Okay, so that's good to know. And the reason I was asking about the pain piece of things was to kind of get at the constipation. So, you know, I've worked with kids over time that have had both constipation that was driving their fecal manipulation, if you will, and then also kind of thinking through that constipation. The consistency is really important. Some kids, as you may or may not know, will have constipation, but it can look like they don't because some of their stools are very loose and runny, but then in reality they are pretty plugged up there. So, and that can cause a lot of pain and discomfort, or at least just discomfort. So that's kind of why I was wondering about that. So then my other question, one is about I noticed that he has an oppositional defiant disorder diagnosis. When you're working with him, do you notice much oppositional behavior?
Yes, we've worked really, really hard with those behaviors. But yes, there is still some different things, like, for example, like negotiating rules. That's a big one, and especially, you know, sometimes for apparent no reason, like not a big change, but it has to do it his way type of thing. He's definitely come a long way. So, and we've noticed that things are more controlled during session than they are outside of session. Probably has to do with the follow through the parents have, and but yes, still observe in session occasionally.
Okay. 2 more questions. So his medications, does he have a psychiatrist or who manages those medications?
Yes, he has a psychiatrist. Mom calls him the head doctor, but yes, it is a psychiatrist.
Okay. I asked because he's on quite a bit of medicine, actually, especially given the degree of his symptoms currently. So meaning, you know, I know we didn't talk about much besides this current problem, but something to keep in mind as you're working with him. It's okay to also reduce the medicine, and so you might want to encourage mom as you're thinking about things. I know this is recommendations, sorry, Joy, but you're just thinking about those medicines, because those medicines can have an impact on your gut too. And again, you know, this could be strictly behavioral, but it's important for us to think about this first from a medical standpoint, because new onset fecal smearing in a 13-year-old is obviously not terribly common, and certainly not something that we can just chalk up to behavior until we've ruled out any of the underlying stuff, including medications playing a role in, for example, making you more constipated. Certainly not saying the medicines are going to cause you to do, you know, rectal digging, but something just to kind of for us to keep in mind. Last question. I know you said you recommended to the family to go to the GI doctor, but has the family, and I know the family hasn't been able to follow through with that at this point, but what about the pediatrician? Would they be willing to go to the regular doctor to see them about this issue?
Yeah, that was another, so that was, if we can't go to a specialist, can you go to your doctor and just check in on this? And they haven't followed through with it. I mean, they give me a different number of reasons why they haven't, you know, but I don't know. It seems like it's a big priority, and I don't know if it, I don't know really what the reason would be behind it of not taking him. But no, they haven't, and this has been suggested.
Okay, got it. Thank you.
Yes.
Thank you so much. And that was actually going to be one of my questions for you as well, Kristen, is, you know, if any of these medications, if there would be concern or with it leading to something such as constipation as well, because he is on quite a high number of them.
He is, and specifically those, none of those specific medications, quote unquote, cause constipation, but at the same time, there are other side effects of them, such as, you know, decreased appetite, also therefore follows decreased drinking, you know, different things like that, that could have a vicarious effect on the consistency of your stools. And so that's kind of what I was thinking about too. And then in general, the medications I was also kind of curious about. So yeah.
Great. Thank you so much. And Sarah Baca, I was hoping that we could get the parent perspective from you in thinking about how the families had some recommendations to see their physician, and they have a lot on their plate. And so from a parent perspective, not only do you have questions right now, but what do you think potentially could be some other barriers that they might be encountering or that you might be able to speak to with this particular family? Oh, and let me unmute you. I apologize. Okay, you're unmuted.
I don't know. I mean, that's so tough to know, but it seems like they have a great support network within each other, and maybe that's what they think they need. Like, and maybe they haven't given it a chance, like to go, like actually just go and see. Maybe they have this, you know, support group meetings can be a little bit challenging, but just go and you never know. They might meet another family there that has a 12-year-old, and then they can connect with each other outside of that realm. And maybe that could be, I don't know, recommendation to where maybe they could find somebody, or even you know, a group in the area that you can talk to, that the technician can talk to see if there's another 12-year-old that they can connect with that's on the same, you know, higher functioning level. The other thing that I'm wondering is if they're still in a little bit of denial. I don't know. I mean, the kid's 12, but, you know, is there some denial still? I don't know. Maybe that was my other question. But.
Mm-hmm. Yeah, well, first, that is a very unique perspective, and I appreciate you sharing the piece of them maybe feeling like they have that strong support network with each other. Mm-hmm. And I think it's something that sometimes I know I don't necessarily think about whether they feel like maybe they already have that system built within their immediate family. And so often we do make that recommendation to connect with other parents and support groups. And that has been feedback we sometimes receive from families, that it's not necessarily as supportive as what they're receiving within their own in-family network. And so I think
sometimes it takes a little bit of time. You know, I mean, you go to a support group meeting or an event, and you meet somebody, and then you keep going, and then you just establish this relationship with one another. And I know it's so hard as a parent to go to these types of things, but it does pay off in the end. Mm-hmm. And I know that you just have to give it a chance. And I know it's like you don't know what to expect when you go, and I think that's kind of what holds a lot of people back.
Mm-hmm.
So.
Great, thank you. And Christelle, did you want to speak to her question regarding whether there potentially is still some denial?
I think it's a possibility. In some instance, they've expressed how, you know, I don't know, like how all the kids are like about the same, like they have a teenager, a 17-year-old, and they have also sorts of issues with, you know, so like they try to normalize some of the issues that they're seeing with this kid and say, well, it happens with my other kids in some other way. So my 4-year-old still has some tantrums, and they're very big, you know, so things like that where there could be. But something that they had brought up to the conversation, or to the, you know, I didn't ask specifically about this, but they just kind of shared with me that I think it was the doctor, the specialist that suggested in the past that maybe there's going to be a point where maybe some of his behaviors are getting too intense, and they have to restrict so much their home environment, like locking, alarms, different things, that it's not going to be possible to control all that, and maybe they should be looking into a placement in the future. And this was something that the parents took very heavily, and was a big, you know, something that caused a big issue in the household for a little while, and then just things kind of calmed down. And when this behavior started happening, Dad brought it back to the conversation and said, you know, is it getting to the point where we cannot control this thing? It's in our house. We cannot monitor it 100%. We cannot do a lot of things that maybe a clinic could. So I don't know, that just the fact that Dad brought it. So maybe Mom more in denial, but that seems to be more down to earth and to the severity of some of these behaviors.
Mhm. Okay, great. Thank you.
One more question. Is he like pretty sensory seeking? I mean, has he been like that in the past? He likes the flub or flab or whatever that stuff is called. Is he more of a sensory seeker?
He likes music, and he likes really loud music. Regarding things to touching, it's been the flurp, it's been, what is that called? The thing that makes a fart noise and that is like really soft. He likes that. So there's been a few things, water, things that cause some type of interaction, but like, and playing with it. But just, that's been it about.
That's, I would think as a parent that would be like, he's looking for some sort of like, you know, to fill his sensory needs, and he's in the bathroom. It's like, hey, this is soft. It feels like, you know, the other stuff that he likes to play with. I don't know. But I don't know. I mean, that's what I would question, if that has something to do with that sensory behavior.
Great. Thank you so much, Sarah. I appreciate your perspective on that. So I actually had a couple questions too, Christelle. Looking at the FAST, I noticed that the parents had completed the FAST and that automatic positive and automatic negative were both elevated. And so for the automatic negative, for the pain attenuation, I was wondering if you could speak to what particularly within that was potentially elevated, because I thought that was interesting that that was also elevated as well.
I will like to open the FAST to go. I think it was the first and last question that they marked down as positive on the section that regarding to, I can't remember specifically the questions.
Okay. Well, and the reason why I was asking is because since the parents have not yet been able to schedule a meeting with the primary care physician, I think she's referencing the actual form. Since they haven't been able to schedule a visit with the primary care physician, potentially being able to speak to them about the fact that when they reported on these questions, this was something, the pain attenuation was something that had been elevated in their responses. And so that might be some information that might be beneficial to help provide to them and why it's important that they seek out that medical consult before any additional interventions are implemented.
So I just opened the FAST, and the questions they answer yes to, where is a problem behavior, is a problem behavior cyclical? So they answer yes, saying that it happened in the past and then it stopped for a while and then it came back. So that was their reasoning behind answering yes to that one. And then the second question they answered yes to was, does the person have recurrent painful conditions such as ear infections or allergies? Not necessarily ear infections or allergies. He's had other issues like constipation in the past, and they said, well, that was painful when it was happening, so and that happened frequently when he was younger. So those were the two questions they answered yes to.
Okay, perfect. Thank you. And then I was wondering if you could describe a little bit more when they're checking on him, they're monitoring him in the bathroom. What does that schedule look like, the frequency, and is it pretty visible, and is he aware that they're checking on him?
So during our intervention phase, it was pretty obvious that we were monitoring him. Door was always left open. When he was having a bowel movement, Mom was passing by about every 5 minutes to monitor and also to speed up the process. He has some tendencies to take a long time, certain activities like taking a shower or brushing his teeth, because he has to do it in certain ways. So like Mom was trying to make sure that things will go at a certain path that was reasonable. That also, I think, goes back to some of the controlling access to water and not wasting water. It's a big family, and the financial situation is a concern. So she wanted to make sure that he wasn't flushing 3 times or that he wasn't engaging in things like that. But so it was pretty often, and during the shower, she was monitoring at least 3-4 times during the whole shower time. So outside of session, now outside of session, it was, from what she says, it was happening about the same way. But that's, I mean, we don't know for sure if that's actually what's actually happening.
Mm-hmm.
Okay, great. And you were mentioning that his routines tend to take a longer period of time. What is his average showering routine timeline, and do you have anything structured to for him within that?
Yes, so when we started working with him, his shower lasted 2 hours, and that was a big concern for the parents because he was wasting water, and also sometimes after the 2 hours, he had not finished actually showering. So the parents had to go in for the last, 5 minutes and make sure that he washed his hair and everything. So there's been a program based on the showering, and that's how we've started monitoring during session showering. And now it's about 15 to 20 minutes consistently. He has a good program that he actually enjoys, and he's very successful at it, following through most of the steps. That actually has been mastered, and we are planning on moving it more into like a self-monitoring thing where he can just tell us that he's following all the steps within the frame.
Mm-hmm. Okay, excellent. And the FLARP and other sensory stimuli, does he have access to it outside of the bathroom and inside the bathroom?
Not inside of the bathroom. Well, currently he doesn't have access at all. But when we were giving access not inside of the bathroom, the parents felt really strongly about not giving access inside of the bathroom, that it wasn't appropriate. So they said this table is going to be used for this. It's right next to the bathroom. You can use it anytime, just right after you finish in the bathroom. I think it also had to do with the fact that if you're playing with the FLARP, you're going to spend a half hour extra in there. So using the bathroom for and avoiding other people to be able to access the bathroom.
Okay, perfect. And then very last question: what are they doing when they do find that he has either under their nails or they're finding it in the bathroom somewhere? What are the procedures that they were following through with?
So the first few instances before this was even discussed with us, the parents still go back into screaming and yelling, and obviously this was something that caught them by surprise. So there was a big emotional reaction that came after seeing feces in the bathroom and him playing or engaging with it. Like at the beginning was screaming, "Why are you doing this? And you shouldn't do this. You're old enough." Like, and I'm saying it very nicely, like she was very upset, both of them were. Dad is less emotional in his reactions, but he has a kind of military way of saying things like, "You should not do this." And it's very, very emotional, but it's not as loud, let's say, as Mom is. But that was their initial reaction. And, we don't necessarily have proof that this is completely based by attention, but we did coach them to not provide any extra interaction, because we know that his other behaviors are sometimes based by that attention that he gets from both of his parents. So we didn't want to make this even worse by providing intense reaction when an instance happens. So they've done a lot of a better job of controlling themselves, and even like leaving and having, that moment alone, and then coming back and saying, "Okay, let's clean this up," and, just in a neutral tone of voice. But this is always a challenging situation. And if it happens where it's a new thing, so if they notice it now somewhere else, like I think there was one time that they noticed it on the towels, but while his little brother was drying the towel, and the towel had that feces in it. So like that was a big, a new situation, and it goes back to that old habits of like, let's scream and get it out.
Mm-hmm. Okay, great. So much. And there's some additional questions, but I'm sure Tina will want to get into some of that as well. And regarding the school piece, I think Zoe is probably going to have some additional questions around that piece of it, probably also as it relates to the behavior and as it was occurring, and also the timeline of when he started with his new school. So Zoe, would you like to go next and follow up with your clarifying questions?
Sure. I actually, there's been just a lot of great information provided. So I think that some of the pieces around school, it seems like the some of the questions that I would have had have been answered in terms of whether it's happening at school. Sounds like there's a lot of questions because of the challenges around being able to monitor him, but that there at least is something occurring at school because he comes home and sometimes it's his hands smell or it's under his fingernails. So I guess, again, I'm a social worker by license, and so I come at it, although having behavioral training for sure, come at it from a little bit different of a perspective. And I have some questions just about sort of environmental pieces, which I think Joy was alluding to, in terms of for a child to go into a school that is set up for kids with that are, emotionally disturbed, or the school not recognizing his autism diagnosis. So I was wondering if there was any talk, if he expressed anything around that process in terms of it being hard for him, or if there were other behaviors that were observed during that time. It's a lot of transition.
Yes, there definitely was a big transition, and he was more and more open to talking about this, what he felt in those situations, and that was really great to see. Well, I mean, something that we know had happened while he was in this school, the school he was moved on to originally, he was allowed to have some of his visuals for emotional regulation in there. So he was using them successfully. And then this kid came and destroyed one of his visuals. So he got really, really upset at that and threw a book. He didn't throw the book to the kid, but he threw a book to the floor. And I think it was this kid's book. So the kid got really upset, punched him in the nose, and broke his nose. And physically, he did not react to that, but so he was taken to the emergency room, and it was a big situation behind it. And after that incident, he was like, I don't want to go there, these kids are mean. And then he started saying like, oh, if I see this kid again, I'm gonna break his nose, and things like that too. So I think it was a big issue around the whole thing, and the parents obviously were very scared of sending him there, but they didn't have a choice. It was just a whole situation. He was placed in this PBIS room within that school, and it was a little better environment, and that's where I think mom more than anything found a little bit of reassurance of him being there, because she found someone that was able to help her put on that IEP and all his documents that he needed a re-eval, and that he needed some modifications to his work, and that he needed a PBIS class from now on. And thankfully, because of that person that helped her, now he is in a PBIS school, and he's scheduled for a re-eval that should have already been done, but it just hasn't. So I think, it was a set of challenges, and he will express how stressful it was, and so yeah.
And given that he's able to express, has anybody asked him why he's smearing with his feces, and why he's sort of got a preoccupation?
We ask him because he is, we have a Telling the Truth program, and it's been very successful around other behaviors. So it's a safe environment to tell the truth about things, and that is the one thing that his answer is, I do not want to talk about. He just doesn't want to talk at all. I was surprised he even answered some questions about his movements in general, of like they're normal. Oh, I do this, I go at this times, and because that's new. Like he in the past would have not want to talk about anything related to it. So it's progress.
Yeah, it's huge progress. To get, I think, a 13-year-old to talk about anything that has to do with stuff that is sort of sensitive in nature is great. So another sensitive subject for teenagers, I think about a 13-year-old, and I think about emerging sexuality, right? And is there any other, self-stimulatory behavior around that? Is he masturbating? Is there any other behaviors that you're seeing or the family is reporting?
Not at this time. The only thing is, his iPad is a big reinforcer, so they caught him watching porn. But nothing like self-stimulatory type of behaviors that they've observed.
when did they catch him watching porn?
It was about a month ago, and it was only that one time. And you know, their reaction was to take the iPad away and have him earn it the next day and kind of limit the websites that he was watching.
Okay. And again, what is the timeline when this behavior reemerged? I know Mom has some questions about when it did actually reemerge, but when did it become noticeable?
It's been about 2.5 months or so.
So 6 weeks? Yes? Okay.
Sorry, 2.5 months.
2 months. Sorry. Thank you.
Thank you.
Great.
Thank
you.
you. Thank you. Those were excellent questions. And Tina, I'm interested to hear your perspective, both from the clinical psychologist side as well as your behavioral expertise in terms of the comorbid conditions that are diagnoses and other underlying questions regarding the environmental factors that might be contributing to this. And let me unmute you as well.
Okay, can you hear me now?
Yes, we can.
Okay, perfect. Well, honestly, so many of the questions that I had have been asked and answered, which is fantastic. I have a few sort of little follow-up questions and maybe just a couple of comments. You know, sort of thinking from that psychologist perspective about the diagnoses that this kid carries with the autism, ADHD, and ODD diagnosis. And I know that Dr. Soul asked about the ODD diagnosis as well. I guess I'm still curious about that one in particular. In presenting the case, I haven't really heard much that's made me think that this kid is exhibiting symptoms of ODD layered on top of his ADD or ADHD and ASD diagnoses. Are there other things there that we need to be mindful of in sort of conceptualizing this case? Does that make sense? Other ODD symptoms?
Well, I think throughout the course of 11 months, we've seen different things, like, for example, stealing behavior, stealing different items. Sorry? Oh, stealing different items, taking them to school, lying to an extent of lying and making elaborate lies, and like pretending that he had a broken leg, and so he stole crutches, took them to school, had other kids follow him behind with books and carrying his backpack. If there's a rule being told specifically by parents, there's a new rule, like you shouldn't do this specifically, then I'm going to do every single attempt to break that rule, and I will find a way of going at it. So those are some of the behaviors we've seen. The stealing has been a big one. Stealing food, stealing other items like dad's knife. What other things? I don't know if you're, sorry?
Go ahead.
No, I wasn't sure if you're looking of something in specific that maybe.
No, you know, and I think that this is one of those kind of tricky areas, right? So as a psychologist who's getting just this really quick snapshot of his behavior, it's certainly inappropriate of me to sort of question the diagnosis. I think generally, though, for the audience on the call who's sort of thinking about autism and what that means and what it means to carry these comorbid conditions, I would just sort of throw out a cautionary note that sometimes we'll add a secondary diagnosis like ODD, and it's incredibly appropriate, right? The symptoms definitely support the addition of that diagnosis. In other cases, it may not be, and I think one of the harmful things about thinking about diagnosing a kid with ODD, if indeed it's not a well-supported diagnosis, is that it may support some of that emotional responding that you see on the part of the parents and other people in that child's environment, right? If what's happening, not just with sort of the fecal smearing, but other behaviors that are manifesting themselves, is really linked to that ASD diagnosis and linked in some direct or indirect way to those core features, it can really shift the way we think about what's going on for the kiddo versus an oppositional kid, right, who's engaging in behavior that may be manipulative with a level of intentionality that a kid with ASD may or may not be able to even have, given some deficits in perspective taking and emotional awareness and what have you. So I think, just think about that and sort of what that diagnosis might mean for him. But it sounds like, as far as what you're thinking about for intervention techniques, that hasn't in any way I think negatively impacted the direction you're going with the case or the way in which you're working with him at all, which is fantastic. So that's what I was wondering about the ODD piece with him. I think the other thing I was curious about, and I'm so glad Zoe asked, was sort of that language piece, and is he willing to talk about what's going on? And I guess one of the things, just to elaborate on that with another question, is are there other services being rendered for this kiddo? And do any of those services create sort of a safe space where he has an opportunity to talk with someone? Does he have sort of a person, right, whether it be a psychologist, a social worker, another therapist, or someone on your team that you think, even if he's not willing to talk about what's happening now, candidly, that he might be over time with some additional rapport building?
So he was attending counseling in the past. It's been a little while, so it was probably at the beginning of our treatment, so it's been about a year. And the mom said that he just will sit there and wouldn't talk to her at all. So the psychologist or the counselor, I'm not sure what her area was, but she just determined that it wasn't useful, and then she stopped services at that point. Something that we've noticed is that his rapport with the behavior technician is amazing, is really wonderful. And there's been times where, like, let's say he is having a bad day and he even tells her, I hate you so much, I wish you'll leave, like, I don't like you, but all these sorts of things. And then next day he comes back all by himself without us telling him anything. He comes back and he says, you know what, I need to tell you something. I kind of need to get this off my chest. And he uses really awesome words like, I need to get this off my chest. I am so sorry about what I told you. I really don't hate you. I really like you so much, and you're a great person. So there's been times when or things that, like, we ask in the truth-telling type of program, and he's not willing to talk about them then, but then later on he comes back and says, I shouldn't have done that. I know that you've told me about this strategy, and I think it would have worked in this situation, and things like that. So I think, although it's in a formal relationship as a counselor, I think he does look back to his behavior technician as a friend or as someone that is safe to tell things to.
I think that's phenomenal, and I think, as Zoe said too, it's just so hard to get teenagers to open up, teenagers with a social disability to open up, especially if there's some of the features of his presentation like you've shared with us. And so I think that's a real testament to the technician's relationship. And I think, I would just encourage you to continue to have them facilitate that and try to find little pieces of what's going on that he might be willing to answer, right? A little bit of that momentum building, if you will. So if he's not willing to talk about sort of a hard question about, rectal digging, is he able to talk about other aspects, sort of post-behavior cleanup or sort of messiness or what other sort of features of the problem, and just over time maybe getting him to talk about that. With a kid with this level of language skills, I think that there's something in that could be really helpful, but it may take a little time, right? It may not go as fast as you want, but it sounds like you're really well positioned to get there. And going along with that a little bit, sort of sticking with this theme, you mentioned earlier that he seemed to be embarrassed, right? And I'm wondering, and this is probably the most minimalistic question you're going to have me hear me ask as a behaviorally oriented psychologist, but is your sense that he is avoiding, that what you're reading as embarrassment is him avoiding punishment, right? Whether it's the yelling or the screaming or the chastising or whatever from the parent sort of punishment, or is it avoidance of being found out in a way that allows him to essentially avoid feeling shamed? Does that make sense? What is that embarrassment really?
I think it could could be a combination of both, but I mean, if I have to guess, in other behaviors, I don't think that being screamed or yelled by mom is necessarily a punishment at all. I think that specifically as dad, can you guys hear me? Okay.
The audio is a little strange. Can you speak one more time?
Is it better?
Yes, that's much better.
Yeah.
Okay, good. So I don't think it's necessarily a punishment for him to be scream and yelled. If that interaction is coming from dad, it seems to be a little more punishing, let's say, from him, because like he wants his interaction with his dad to be more positive than he cares much of, being screamed or yelled by his mom. So that being said, I don't know necessarily he's avoiding that. He could be avoiding the fact of having to clean after himself because mom asked him to help her clean whatever he did or whatever, or wash his hands really well. So in that sense, he could be avoiding that. But something that we've noticed is like if mom were to walk in and he has his hand inside the toilet, he'll immediately get it out and say, I wasn't doing anything. Like, what are you talking about? Like trying to kind of hide it.
Mhm.
And now that we are not monitoring, like, so only that it's been like hiding and trying to monitor that way, he found a way of like just peeking his head out so that he could be seen and then by the moment that someone gets in there, he's like, I'm not doing anything, I'm just taking a shower, or something like that. So I don't know if it also has become a little bit of a game of like I'm hiding from them and I will become more proficient at it every time that they try to,
Thank you.
you up it up.
Yeah, thank you, Christelle. I think that that's excellent information. And Tina, I really appreciate you bringing in the perspective of what those comorbid diagnoses might mean for him in terms of how the parents might be approaching it. And I think that that's a great perspective also for us to be thinking about as well. And just in the interest of time, we're going to go ahead and move to the last clarifying questions and then move into recommendations from the panelists. And if you are in the audience and you have recommendations, we'd like to ask you to start putting those into the chat box. And our care coordinator will be gathering those recommendations from the participants.
Hi, Christelle, Kathleen. I just had a brief question for you. I know you mentioned that the family doctor at one point in time was recommending potential out-of-home placement. Is that the psychiatrist that was making the recommendation or the family physician?
The psychiatrist.
Okay, so not the same practitioner that we were recommending the family go see?
No.
Correct. Okay, great. My other question was, does he have any friends?
He made one friend, a girl, and from what mom described, is a little older. From what mom thinks, she's also on the spectrum. And now that's a new relationship from this new school.
Okay, great. And then is it correct that he attended a school that was oriented for children with emotional impairments?
Yes, that was the second school he attended this school year.
Okay. And did it have a psychotherapeutic element? Was he seeing a therapist through that program?
Not that I know of.
Okay, great. Thank you. Those are my questions.
Great. Would you like to start with recommendations?
Yeah, I was wondering, and I think it kind of alludes to what Tina was pointing out as well with his verbal capability, if it would be a recommendation to have him see an outside therapist. And I'm thinking about, he's dealing with his sexuality, it sounds like, and that behavior has been punished somewhat, potentially by the family. Does he have a place to explore and talk about this? And if it wasn't a match with the previous therapist, it doesn't mean that it's not a service that will be successful for him. Potentially it's just not a match with the therapist. I don't know if he may be more comfortable speaking with a male therapist, especially because he is navigating his own sexuality among all these other pieces. Sounds like there was some trauma at the previous school. I don't know if he's worked that out. In addition to some of the family dynamics, I know that the parents you were mentioning respond emotionally to some of these behaviors, and I don't know if he was privy to the conversation about residential placement when that was taking place. I'm just wondering if that might be another good service option for him to work these things out outside of working directly with his family.
Great. Thank you. Tina, would you like to go next and add on to that?
Yes, sorry. I think, I think so. I concur with that recommendation. I think other recommendations that I would probably quickly make is just to, in a lot of ways, stick with what you're doing, right? Keeping the bath time short, engaging in routines and self-monitoring while you're in the bathroom, delivering something that's a powerful reinforcer contingent on not engaging in the problem behavior during that time, continuing with your NCR, which I think is obviously a really critical component, but just, and we didn't get to talk about this, but carefully considering the sensory qualities of the reinforcer you're delivering for NCR and making sure that to the degree possible, you've got a match with what you think is going on with that automatic function. And I think that's it. I mean, otherwise, I think a lot of what you're doing is right on track.
Thank you. Thank you so much. Dr. Soul, would you like to go next?
I'm talking to myself. Okay, so absolutely. I have a couple of thoughts. Obviously, in my mind, one of my top recommendations is to work with the family to help them understand that there might be something going on from the constipation that he had before, and that he really does need to see the doctor for a physical exam. Aside from that, though, one strategy you might find useful is to actually have this young man take his own data on his stools. That would make me feel a lot. And so, for example, you could make like a little chart that talks, you can take a picture. I can send you the poop chart. It's cute. But anyway, like have him rate the consistency of his stools as well as how often he's going. And so, whatever, you probably get the picture. But that could be helpful because then that would at least give us some quantitative data around what his stools look like, if they're painful, how often he's having them. So aside from all the fecal smearing stuff, that way we could at least assess this constipation question. Because, see, the thing is, children with constipation can be very uncomfortable, and so they can start doing this fecal digging and smearing. Well, once they dig, then they see it, and then it just becomes, smearing and other things. So that would be one thing I would suggest. A couple of other things, though. And so can't be more glad that Zoe asked the questions about puberty and also the questions about self-exploration. So puberty is a very common time, as I'm sure most of us know, for these types of explorations. And so sometimes anal stimulation is considered quite pleasing to some people. And so there are some really handy resources out there about puberty and also like healthy body and things like that written for people with autism or children with autism. So we'll make sure we make those available to you. Because I think that's something important for us to look at is there something going on there from a puberty standpoint? And hearing that he's explored pornography, while definitely not uncommon, I'm kind of shocked at how many times I have to have this conversation with families. It does point in the direction of, well, is there something more going on here? Is this part of his self-exploration? And do we need to redirect that to other on not as uncomfortable things. So anyway, those would be my main things to think about. And then lastly, as more of a broader recommendation, I would really encourage the family to talk to their psychiatrist and see if they might try, have a conversation about minimizing his medications. Now that he's in a new school, he's not in such a stressful environment or what sounded like a stressful environment, you might encourage the family just to revisit. All you have to say as a BCBA, because I know that's not necessarily within your scope, but you can just say, hey, have a conversation with your psychiatrist and revisit the medicines. Maybe it's time to make some decreases in the medicines. So that's just more of a global concept, but otherwise, there you go, and we'll make sure those resources get to you.
Wonderful. Thank you so much for those contributions. And Zoe, would you actually also like to speak to that puberty piece and anything else within your recommendations?
I think everybody has covered it. I just think it was an extraordinary presentation, super helpful information, both from the participants and the hub panelists. It's sensitive stuff, and I think really exploring all the areas is really helpful. So that's all I'd have to say. Thanks.
Wonderful. Thank you so much. And Sarah, love to get your perspective as well and recommendations, and I will unmute you.
I just wanted to and thank you for pointing out to the parents that they're doing a good job. I think sometimes that gets overlooked, and it's really important to families that you remind them that they're doing a great job, and just encouragement is always amazing and makes you feel really good, especially whenever you have things can be going really, really well, and then things take a huge turn for the worst. And just your encouragement really means a lot as a parent, and that's it.
Wonderful. Thank you very much. And I agree with you completely. I think that being able to reinforce the parents for all the work that they're doing, especially when they are taking the recommendations from their psychiatrist about maybe him needing to be placed in a higher level of care or a residential setting, and that they feel like they're not able to work with him in the home. And I know that that's been very stressful and difficult for the family, thinking about those pieces. And so with the recommendations in summary, we are obviously still recommending that they seek a medical consultation to rule out any underlying issues, which I know that you've already recommended, and that's wonderful. So once they've had that opportunity to do so, then continuing to explore whether this is something that might be related to puberty, sending some additional information as well. And if it is, then I think that will direct the treatment to something that will be a little more socially acceptable. And then outside of that, potentially if it's not related, continuing with a lot of the interventions, as Dr. Goldsmith was mentioning, related to the self-monitoring. I think the self-monitoring of a stool and bowel movements is excellent as well, and that's a great recommendation. Thank you, Kristen, for that piece of it. Thinking too about if it is self-stimulatory but not related maybe to his puberty, thinking about, as Tina had brought up as well, the different types of stimuli that we're providing him access to, and maybe creating more of a sensory kit that has more than one item besides the FLARP, and that also maybe the parents would be comfortable with incorporating even within his shower routine. That might be acceptable. So whether that might be shaving cream. I mean, I know that they don't want to bring it in the bathroom for sanitary reasons, but he's also engaging in the behavior during that shower time as well. So there might be some other things that could be incorporated is that he can select from both inside and outside of his bathroom routines, and then continuing to think about that self-monitoring and structuring, and potentially putting some additional time limits within the sessions or this showering sessions as well. So we will go ahead and get all of that included and put those into the recommendation folder, and you'll have access to that immediately via email, and then the participants will have access on our website. We usually post within the next week. So thank you all very much for participating today. Christelle, you did not only an amazing job presenting, but you've done such an amazing job just coordinating care and working with the family thus far, and so we appreciate you.
Thank you so much. Thank you for all the feedback. That was great.